Good evening, everyone. Today, case discussion is a 48-year-old female. Good evening, everyone. Yes, thank you, sir. Today, case discussion. 48-year-old female. She is a homemaker from West Bengal. Presented with chief complaints of cough since 3 months and history of present illness. Patient complaint of cough since last 3 months, which was gradual in onset and had aggravated since last 15 days, and it was associated with white color sputum and occasionally mixed with streaks of blood without any postural variation or aggravating and relieving factors. There is a history of loss of appetite since last 1 month and a history of unintentional weight loss of about 5 kgs in last 1 month, and there is no history of chest pain, shortness of breath or palpitations, swelling of face or upper limbs, no hoarseness of voice or ptosis, no history of jaundice, headache, vomitings or seizures. Past history, there is no history of similar complaints in the past, no history of tuberculosis or asthma or heart disease, no history of any past surgeries. She is a non-hypertensive since last 10 years on telmisartan. Personal history, she is married with 2 kids, no history of bowel or bladder disturbances, and she denies any addiction. Family history, there is no similar complaints in family, there is no history of TB in family members, there is no history of malignancies in the family. And treatment history, patient received antibiotics and cough suppressants, after which there is a mild improvement in the cough, but symptoms has recurred after stopping cough suppressants. And the summary, 48-year-old lady, non-hypertensive, presented with complaints of chronic cough with which is gradually in onset and aggravated since last 15 days. It was associated with sputum, occasionally mixed with blood streaks, and it is the complaints are associated with loss of appetite and unintentional weight loss of 5 kgs in last 1 month. And the possible differentials will be pulmonary tuberculosis, and next is carcinoma lung.
Why you thought it is in your differential diagnosis lung carcinoma?
Because of significant loss of weight and aggressiveness, which is increased in last 15 days. There is increasing in cough and increasing in loss of weight.
All these things can appear in tuberculosis also, no?
Yes, sir.
What made you to think that it can be a possibility of malignancy?
Only thing is that the symptoms is increased in last 15 days. In tuberculosis, it's more like an indolent one. So my second differential is carcinoma lung, and the first differential is TB.
So how common in a young lady carcinoma lung, in fact in a non-smokers? Why you thought of carcinoma lung? Because okay, pulmonary tuberculosis is acceptable.
Yes.
Because you are working in an oncology center, you thought like that. Okay, continue.
On general examination, patient is conscious, coherent, cooperative and oriented with ECOG performance score of 1, height of 150 centimeters, weight of 66 kgs with BSA of 1.65 meter square, temperature is 98 degree Fahrenheit, BP is 120 by 70 mm of Hg in right upper limb in supine position. Respiratory rate is 24 per minute, regular, and the saturation is 97% on room air. There is no pallor, icterus or facial edema or clubbing. No supraclavicular lymph nodes is palpable. There is no bony tenderness elicited. With this above complaints, I want to first examine the respiratory system. Upper respiratory tract, throat and nasal cavity is normal. On inspection, chest is symmetrical and respiratory movements are decreased on right side. Trachea is in midline. No signs of volume loss like drooping of shoulder or rib crowding. No dilated veins, sinuses or visible pulsations. No usage of accessory muscles of respiration. On palpation, all the inspector findings are confirmed, and percussion, there is dull note in right supraclavicular, infraclavicular and mammary areas. And on auscultation, there is decreased air entry on right supraclavicular, infraclavicular and mammary areas. Cardiovascular examination, it's normal. Per abdomen, there is no organomegaly, there is no ascites. And CNS examination, higher mental functions was normal, and there is no motor or sensory deficits.
investigation would you like to do? Because now you, from your clinical finding, there is a effusion, is there? Air entry is
There
low.
is mass-like lesion in the right upper lobe and middle lobe.
Okay. What investigation, first investigation would like to do if you see a patient like this?
First, I want to go ahead with chest X-ray.
Yeah. You have done the chest X-ray was done in this patient?
Actually, the patient came with the CT thorax. So.
Okay. Okay. Otherwise, you would have.
Otherwise, first investigation with chest X-ray, then her labs, functional assessment of the patient. Her hemoglobin was 12.7, total count of 7.8, platelets of 393, and the serum creatinine was 0.6, electrolytes are normal, albumin of 4, bilirubin of 0.4, and AST ALT at 20 and 25. CT thorax was done outside. It showed a necrotizing consolidation in right upper lobe with ground glassing with smooth septal thickening in right lung apex and multiple small rounded cavitary pulmonary nodules with showing surrounding GGOs in the rest of the lung, in both lungs. She underwent a lung biopsy. It showed adenocarcinoma, EGFR AL cross as being negative, and PDL1 with TPS score of 20%. For staging workup, we underwent, we did her MRI brain and FDG PET. MRI brain showed there is no metastasis in the brain, and in PET CT it showed FDG avid lesion in right upper lobe of measuring 13 into 7.6 centimeter with SUV of 16.7 and few areas of consolidation right lung middle lobe with patchy increased FDG uptake and multiple subcentimetric cavitary lesions scattered in both lungs with surrounding GGOs, and there is no significant pleural or pericardial effusion. There are mediastinal nodes, right upper and lower paratracheal, subcarinal nodes, largest being 19 mm with SUV of 6.19, and the right cervical level 4 level 4 node which is subcentimetric with SUV of 3.3, and there is no other metabolically active site. These are her images.
What will be the TNM staging based on this one?
It's T4 into M1A. 4. It's 13 centimeter mass.
N?
13 centimeter mass.
Okay. N?
N2.
Why N2? Supraclavicular node is there, no? That to become N3.
N3. Yes. N3.
Okay. M status?
M1. It's a bilateral lung lesions.
M1.
M1A.
M1A. Okay.
And the final diagnosis is carcinoma lung with the clinical stage of T4, N3, M1A, adenocarcinoma. And my plan for this patient will be first 4 cycles of pemetrexed with the carboplatin with the pembrolizumab. Then after 4 cycles, response assessment.
No, basically, you see, she's a young lady, 48-year-old, adenocarcinoma, non-smoker. So just based on the EGFR, ALK, ROS1 and taking PDL1 as positive, you would like to add immunotherapy, or you want to do any next generation sequencing?
I want to get a NGS done to see any other driver mutation, and want to go ahead with.
Often we do get into these mutations in the NGS and which might have missed on the IHCs. Yes. So adding immunotherapy sometimes can be detrimental also. So it is right because you have seen the EGFR, ALK, ROS1 negative, and you have started on the pembrolizumab. How was the response? How many cycles were given?
Till now she completed her second cycle. She is clinically better. She is responding.
And you have sent for the NGS?
Yes, sir, we have sent for the NGS. It's awaiting.
It is awaiting.
By sir, a 48-year-old non-smoker, we should always look for driver mutations before starting the immunotherapy or any other therapy.
Yes, we started treatment for her because of the complaints of hemoptysis. The frequency and the quantity of the blood was increasing day by day, so we planned for treatment. Then it's her NGS is awaiting now.
How is she responded now?
Now she is much better. Cough is subsided, and hemostasis also it's decreased.
Any interim CT has been done?
No, ma'am. We are planned to do response assessment after 4 cycles.
If you find tomorrow your NGS report comes that there is a EML4 fusion mutation, what will you do?
Then we will stop the chemotherapy and we'll start her on ALK-directed therapies.
So, based on the PDL1, what was the PDL1?
It was 20%, sir.
20%.
20.
So, if you find any co-mutations also are there, like as Madam presented in the previous one, like STK11 or KEAP1 in the NGS, or KRAS is wild type. How are the chances of she responding to immunotherapy, chemoimmunotherapy?
KRAS and STK, she will respond better when compared to EGFR and HER2. These patients with KRAS mutation, they will respond they will respond better to immunotherapy compared to EGFR.
Any other presentation?
No, sir. This single one presentation.
Only. Any questions from? Okay, thank you.
Thank you, sir.